much for having me here today. I know we are running late, but I will try to speed up the panel. If my panelists give me crisp, short answers, we can move fast. I think we are waiting for one more person. Should I start anyways? Should I start? Okay. So, I'm not able to see all of you, but the screen is there for you, I think. Are you able to see this there? Yeah, that's good. That's great. So, congratulations to Team E3Con. This is my first visit to Kurnool. I had a pleasant drive this morning. And I have Dr. Saujanya, who's an alumni from Fernandez Hospital on the panel, which is also a good thing for me. So, I'm somebody familiar. Thank you for inviting me to this. So, without further ado, we'll just move on. Placenta equita. Before I start off the panel, I will ask the audience how many of you have actually faced placenta equita in your clinical settings? How many have operated on them? Do you get them routinely? What do you do? Do you refer them? Do you tackle them? How many of you tackle them? I can barely see 2 or 3. Yeah, I know none of us want to if given a choice, isn't it? It's very, very stressful. I welcome the 4th panelist. It's moving. Now, this is the terminology we are all supposed to use. Placenta equita spectrum. PASD is the current terminology by FIBO. We should give up the terms like abnormally or adherent or invasive placenta, morbidly adherent placenta. All these terms we have to give up. Although still it is quite confusing and people continue with their old terminology, but this is the recommended terminology. And PAS includes all grades of abnormal placentation. They classify it into 3 grades. Grade 1 is when the villi adhere to the myometrium. Grade 2 is when the villi invade the myometrium, that is increta. And grade 3 is serosa and beyond, which is perpetua. But this is the FIBO terminology. For all postgraduates, they must be aware of this. It's moving there. Anyways, I can look there and do it, but on the laptop, the slides are not good. Anyways, so we all know why equita happens. Defective basalis layer. So let's not go into the theory so that we just move on to the practical aspects. It's a significant challenge. We all have come across a lot of morbidity to the mother, to the baby, sometimes even mortality. So we don't want that. And you won't believe this was first reported in 1930s. It's there, but very, very rare. When we did post-graduation, we hardly ever saw an equita. In all our years of post-graduation, maybe I was seeing 1. Now, since I've come to Fernandez, we've done almost 150 cases. It's on the rise, believe you me. I hope you place this time. It is not my laptop as well. Your own laptop. You confirm. How do you all confirm what it is? Only by looking at surgery? By scan? Histopathology, yes. So histopathology is extremely important to grade the degree of invasion. Don't forget to send the placenta. We actually teach our postgraduates to cut the uterus, look the invasion on the myometrial wall. In the upper part, you see beautifully thick myometrium. In the lower part, it thins off and nothing but the placenta is there. So very, very important teaching point in OT. Right, we know why this is happening. Now to my panelists. So I'm Dr. Padmaja. Dr. Snigdha, is it? Okay, we'll start from Dr. Snigdha. Why do you think morbidly adherent placenta or placenta equita spectrum is on the rise? Do you agree with me it's increasing?
Can you repeat your question, ma'am?
Why is placenta equita spectrum on the rise? Why is it increasing these days?
As we all know that of late the rate of cesarean sections has been increased everywhere, and to my knowledge, it is being done by everybody. not by qualified people in a manner it is to be done. They are not doing it in a speculated manner. So because of all these things, I can see that difference in not only in this Akrita spectrum but all other complications are also because of that.
Dr. Saujanya, is there anything in that you would recommend to prevent this happening?
We have traditionally taught to suture it in 2 layers. So that is true even for today. In between we have seen some changes like suturing in a single layer and all. But still I feel better to suture it in a classical way of 2 layers and not to deal too much of interference with
we should not disturb the residua, we should not get it everted or inverted, just maintain the continuity. That is extremely important. There may be other things we are not aware of. Maybe the suture material has something to, we don't have proof. So research is still going on. Some people say don't push the bladder too much. Some people say you have to reflect the bladder. So we do not have evidence on the technique of cesarean that will prevent Akrita, but we have to keep looking at research. Doctor,
that PAC is potentially catastrophic. It increases maternal morbidity, mortality, perinatal morbidity, mortality. We may be delivering it early, and more injury when we are dealing with during surgery, injury to bladder, ureter, more number of hemorrhages, more and more demanding for blood transfusions and associated complications of blood transfusion.
What is the maximum number of blood that 50 units, believe me, 50. It is Patrika, invaded parameter, invaded everywhere. We did 50 units, we packed, we could not get control. We packed the abdomen closed 48 hours later because they will obviously go into the ICU. So it's a bad thing to do. Any actually survived 50 units of blood clots. So that is a rare case. I'm not saying every patient will. Now a lot of techniques are coming to reduce the blood losses. I have Dr. Padmaja. Can we do, ma'am, anything to reduce the occurrence of placenta Akrita?
Yes, ma'am, we can do. Mainly by reducing the primary cesarean section rate.
Absolutely.
We can reduce this
increase your VBACs.
And increase the VBAC.
And reduce unnecessary gynec surgeries. They are all risk factors. Please think twice before you subject anybody to surgery. So this is our responsibility. Indirectly, we are only responsible for the increase in the yes, and unnecessary cesareans. So we all have a social responsibility. I think one of the speakers have raised that topic. I think very pertinent to us. Right. Let's quickly get the answers for the sake of audience. It was once upon a time 1 in 25,000 in the 1950s. Now it is 1 in 500. It's as common as that. It parallels the rising cesarean section rates. If you have a previous section and placenta previa, take it. It could be Akrita. Don't go blindly. Placenta previa, previous section. Okay. Past has become the commonest reason for cesarean hysterectomy now. Once upon a time, in my entire training, I would have seen 1 or 2 for atonic PTH, rarely 1 adherent placenta. Now it is, per month we are doing 6, 8, like that. As Madam rightly said, increased maternal morbidity, mortality as high as 7 to 10%. I have put the persons there because in your consents, you are supposed to inform the incidents. They need to be aware of this. Okay, so don't hide things, don't brush it off. It's an important complication we have to mention. And of course, lot of hemorrhage, blood products, ICU care, bulky organ failure, you name it, they are at risk for all of these. And risk increases as the number of cesareans increase. Okay, nowadays we are seeing more Akritas with just 1 cesarean only. I don't know what is the rationale, but we are saying more than 3, obviously the risk is as high as 70% of aplasia and therefore adherence. So our responsibility, we must take a conscious effort to reduce uterine surgeries. That is a learning point from all of this, especially in young women. Now again, how would you diagnose adherent placenta, Dr. Smita?
So main line of gold standard is always ultrasound, 3G ultrasound if you have the facility, and for confirmation MRI is there, but by doing ultrasound itself we will be able to make out certain things like loss of retroplacental clear halo and presence of abnormal lacunae, and then myometrial thickening less than 1 mm, and the uterine bulge into the bladder, if at all there is exophytic placental mass into the bladder. Some of these, so by looking at it, definitely we will know that we are looking at a case of placental accreta. And then
the others, what is your investigation of choice?
Ultrasound is the investigation of choice, and it should be done by an expert who deals
That
with
is the crucial point. Anybody who can hold a probe should not be doing this. People who are trained, people who are doing this every day in a high volume sector have the consistency to pick it up, even focal adherence.
So
The
those
experience matters.
with post-previous caesarean section with placenta previa and high risk with previous history of placenta accreta should be referred for ultrasound to such centers.
Ma'am, would you agree with that?
Yes, definitely. Senior radiologist along with the operating surgeon should definitely look at what is happening and where is it a focal adherence and how much is invading the myometrium, is it accreta, increta, percreta, we can plan accordingly with the surgery also.
Ma'am, when would you do MRI? Would you do for all, or would you have few cases where you would?
no madam, MRI is not indicated in all cases, and ultrasound is almost equal to MRI, and the specificity and sensitivity is also almost equal to MRI. And MRI is indicated whenever there is a cases in case in the posterior placenta previa, and to know the invasion into the surrounding tissues. So if you suspect any invasion into the bladder or surrounding structures, then you advise the MRI. Routinely it is not indicated.
Absolutely. In the initial years, we would by default ask for MRI. Gradually, we realized it's not adding to anything. A well done ultrasound by an experienced person is as good as an MRI. As Madam said, only if it is inconclusive on scan, very obese woman, or you suspect invasion, or it's a posterior placenta, only in those cases MRI is needed. It's expensive. Don't just order an MRI like that. I think they have given clear answers. Diagnosis. See, clinical suspicion plays an equally important role as equal as ultrasound. You should know, okay, this way, who is likely. It doesn't mean to say no previous surgeries will never get accreta. Rarely they do, but that's extremely rare. But previous surgeries and low placenta, always think about it. And ultrasound with color Doppler, ma'am, even 2D is good enough. But it's good if you have 3D. But with 2D grayscale also you have good pointers to raise the suspicion. MRI in select cases, and don't forget correlation with histopathology. And even in your pathologist should be more experienced in reporting the degree of invasion. Why is this important? For the sonologist, for us to give feedback. Look, you said it is increta and it turned out to be increta. Or you said increta but it's percreta. So they need to also learn and improve, isn't it? So we should complete the loop, audit loop. So what are the risk factors? I think they have all raised it. Previous section, previa, ARTs are also increasing. They are also contributing. Malformations, increased age, multiparity as the parity increases, and other surgeries. Rarely PAS can occur even in women without any of these risk factors. It all depends on what you are seeing on your ultrasound. So don't blindly do the ultrasound. So first line modality, as you've all said, and it is less invasive, widely available, no radiation, safe. Now, before moving to the features on ultrasound, if one of you could elucidate how does a normal placenta look like on ultrasound? Normal placenta. You should know normal before you try to see what is abnormal. How does a normal placenta look like on ultrasound, 2D ultrasound? Anyone?
So the placenta looks like homogeneous, isoechoic, with a retroplacental space clear, retroplacental clear zone, which indicates interbox layer with no lacunae, usually no lacunae, and when we put on color Doppler in the retroplacental space, the blood flow is uniform.
Okay. And when would you want to scan? The woman has booked with you at 7 weeks. She's previous section. So when is it ideal to start suspecting that this could be adherent placenta?
To look at the site of implantation, so as early as possible, around 6 to 7 weeks.
Especially like when there is
If it is low lying, we
Yes.
would be even more cautious.
Yes. But from then on, serially you have to follow up. Okay? Anything you want to add, ma'am?
especially when there is history of previous C-section, there is a cesarean scar defect and nearby the defect, the implantation is there.
Right. So this is how a normal placenta looks like. Uniformly echogenic. See the 2D grayscale is so clear. Homogeneous, deep hypoechoic band between myometrium and the placenta separates it, and normal vasculature. It's not abnormally increased, no lacunae. Okay, this is very important to know that it is normal. Now how and when to scan? Yes, you have answered. There are systematic reviews right from second trimester onwards. In fact, in previous section patients, even in first trimester, depending on the place of implantation, you can guess, okay, which is going to head towards scar pregnancy, and that becomes future equica. Okay, so right from first trimester. So the detection depends on level of experience of the person scanning. It's useful to have a radiologist or an obstetrician doing the scans dedicated to do this. So they will improve case after case, and they are more likely to give you the right report. Okay? They can also tell the degree of invasion. Now let's look at the case scenario. This has happened years ago in our hospital, so we have learned from this case, therefore I am sharing it with you. This is a 32-year-old lady, 2 previous sections. Initially in the 3rd pregnancy she showed elsewhere. Scans said intrauterine pregnancy at 8 weeks. She came to us at 13 weeks to ER with pain abdomen. Okay? We have a small portable machine in the ER, so the doctor there put the probe and said heartbeat is good, everything is good. She gave paracetamol, she booked entry and she sent her. Do you think anything else is needed? Do you think she did it all right? So, yeah.
Should have done a radiologist, referred her for an expert opinion.
She did not look at the implantation site. So it was in the scar. HB dropped to 6.9, emergency laparotomy 2.5 liters blood, ruptured scar, fetus lying in the abdomen. Resuscitation, repaired scar, advised sterilization. She declined, of course, but she was in shock. That's not the right time to take consent for sterilization. But see, what I'm trying to say is do. It's not enough if you look at the heartbeat. You need to know where is it implanted. You also need to know when you're doing first trimester scans, look at the adnexa. Don't forget the adnexa. Oftentimes you've missed heterotopics, you've missed ovarian masses. You know, these are all important, and you can only look at adnexa well in the first trimester. Once you reach second trimester, it's very difficult to see the ovaries and in this time. So people learning to scan, please use the first trimester well, because it will give you clues. So what is the learning lesson from this case? And in scar pregnancy, what do you do, what not to do, very important. So if it is a scar pregnancy, had the doctor identified and informed, what would you do, ma'am, Dr. Padmaja?
Pregnancy. First of all, you have to counsel the patient if it is unruptured. So you have to counsel regarding the complications of cesarean scar pregnancy. And if at all she wants to continue the pregnancy, what could be the prognosis? So there may be increase the chance of the placenta accretus occur if at all the patient wants to continue the pregnancy. So always better to advise the patient to go for termination if at all the patient is willing for termination.
Terminate dilemma there. because we have seen patients with scar implantation going to viability, going home with a baby. Okay, already the implantation happened in the scar. If you are terminated, maybe blood loss may be less, you may be able to get away without many complications, but you are taking the life, this potential life. So our hospital is a pro-life hospital, so we give the options to patients. If they wish to terminate, they go elsewhere, but if they wish to continue, we support them. And we had cases who went home with a baby, but they must be able to understand and make an informed choice. Yes, this is a risky pregnancy and I am willing to take that risk. So all boils down to good counseling, as Madam said. If they wish to terminate, it's their choice. So what not to do, ma'am, Dr. Snigdha, in cesarean scar pregnancy, suppose she opted to terminate, what would you do? So is it like a normal SCRPC?
Yeah, there are medical management and surgical management.
Okay. What are the risks in scar pregnancy?
So if there are two types in cesarean scar pregnancy. Endogenic is relatively it's good.
Yes.
That grows inside the endometrium and she may have a normal delivery and all. But exophytic we are worried about.
So you want to know more
which type
about
of
the scan?
cesarean
Yes.
scar pregnancy it is, I will want to know.
Yeah.
And if it is exophytic, definitely she is going to land either in cesarean scar rupture or she may land in placenta accreta spectrum.
Yes.
That beforehand I will counsel her.
What will you do if she wants that to be removed?
To be removed, there are two options. One is a medical management. For that,
Endophytic,
for
that is fine. But if you are going towards the bladder,
for exophytic, madam, yes, depending upon the size of the gestational sac, less than 9 weeks, it's always good to terminate. And I will look at the beta HCG levels and viability of the fetal heart is there or not. Depending on that, I will inject methotrexate and directly into the sac.
yeah. There are various ways of treatment. Some go for embolization.
That is surgical, next medical.
Yeah.
Once the failed medical is there, then I will go for surgical. Or if she has become hemodynamically unstable also, I will go for surgical. Like I said, depending on the residual myometrial thickness, if it is more than 3 mm, I will go for hysteroscopic suction evacuation. If it is less than 3 mm, I will go with a laparoscopic assisted surgery.
If Dr. Savitri, if we are doing suction evacuation, or she had medical and she is bleeding profusely, and you have to take her to theatre. So anything you would do to reduce the blood loss? Anything else? You can put a surplus. You can ligate the uterines transvaginally. You can put a Foley bulb tamponade. A lot of things have been reported in literature. In our hospital, our first option for such cases would be embolization. We first KCL stop the heartbeat and embolize, and then it will shrink. And afterwards, it will resolve itself. We didn't need to even do surgery, but it will take time. So in all previous section cases, an early pregnancy scan to locate the site of implantation is a must. And a high index of suspicion for scar pregnancy is critical because they don't have symptoms. They come, you put a probe, there's a heartbeat, but where is it implanted? That is extremely important. Unless you suspect, you will not look at it. What not to do? If a scar pregnancy is misdiagnosed and a blind curettage is done, then there is scar rupture, lethal hemorrhage. Sometimes you won't even reach the sac. Complete evacuation not possible. Sometimes you may even cause injury to the bladder. So you have to be very cautious. Have a plan of action before you actually touch the patient. Okay, so coming to ultrasound. What is the right time to do? We all agree serially from first trimester. We keep looking. Can we pick pass in first trimester or only in second, third trimesters on ultrasound? Even in the NT scan, we can get a clue. Okay, so you need not wait for second, third trimesters. That's what I wanted to tell there.
CSP is an entity which is in continuum with the PS.
Yes.
So we have to remember that.
Yes. This is an image of the scar pregnancy. This is the scar. It's implanted here. Look at the peritrophoblastic blood flow. Okay, this is typical of scar pregnancy. Multiple vascular channels within the placental bed. So let's not talk about this. This is also on the rise. second, third trimesters, what do we want to do? This is what you need to know. When you are doing a scan, there are 11 descriptors for adherent placenta. Okay, on 2D breast scale 6, color Doppler 4, power Doppler 3D only 1. Okay, even in 2D is good enough for you to pick it up. So on 2D, what do you see? Loss of clear zone, abnormal lacunae. I think all of you have said these. Bladder wall interruption, myometrial thinning, placental bulge, focal exophytic mass. These are all seen only on 2D. If you have a Doppler, you will see all the hypervascularity, subplacentally, uterovesically. You see those bridging vessels going parallel between myometrium and the bladder. Placental lacunar feeders. On a power Doppler, you will see a lot of hypervascularity. This is loss of clear zone. On that side image, you can see there is no clear zone. This is lacunae. Okay, I am going to run fast. This is bladder wall interruption. This is myometrial thinning, that red arrow. Placental bulge into the bladder. Focal exophytic mass. All these will give you clues. And on color Doppler, look at the vascularity, hypervascularity, subplacental hypervascularity, bridging vessels, those parallel small vessels. When you are actually dissecting the lower segment, these are the ones that will cause a lot of bleeding, and lacunar feeders. Okay, this is how a power angio looks like. It's a mass of blood vessels. Okay, now do you think any scoring system will help plan? Because ultimately for eccrita, what will save us? Good diagnosis, good management plans. Then we can reduce the mortality. So any scoring to tell us this is going to be a bad one, this is okay, I can manage. Kind
The scoring, they have many parameters for the scoring, including whatever you mentioned in the ultrasound checklist. So if it is less than, the score is less than 3, it is supposed to be normal. 3 or more, at least 3 or more, it could be placenta eccrita. If it is 7,
myometrial thickness, the previa, the bridging vessels, and they give a score. Okay, then you know, okay, I need all the team. Okay, I can't tackle this myself. This score also has all this. In Fernandez, we use a checklist. I will show you that. Any role for biomarkers? They're talking a lot about biomarkers now. Back way, you name it, it is there. Pro-BNP, pro-BNP, MR, free beta-LCG, HPL, self-free BNP, but all are non-specific as we speak. FP without any neural tube defect or any fetal anomaly. Okay, so unexplained high FP, think about it. Correlate next time. But these are all non-specific. So this is another score. So this is the checklist we use. What all I mentioned is there. And we put a score at the end, and the clinical primary consultant will then make a plan. Okay, I need this team. So prior referrals are made, blood arrangements are made, family counsel 2-3 times, video counseling, very important. There will be a big group on the day of surgery. When you're counseling, there will be only one person. How much they're understanding, we don't know. So we have learned from it, and we insist on video counseling with the family. MRI, we have already spoken. The systematic review says MRI has the same accuracy in diagnosing past as does a good ultrasound. So please don't waste the money on ultrasound, and don't forget the role of histopathology. Okay? Now management. Quickly, in another 5-10 minutes, I'll wind up. Where would you want to deliver this case, Dr. Srita? Now you have an eccrita, bad score, probably percolator.
Most of the times we admit her beforehand, we will identify such high-risk cases, and we would want to do it on an elective basis. All of us will agree with me, none of us wants to do it on an emergency basis. It's very difficult.
Yeah.
So, but of late, sometimes even if you plan electively, they may land in an emergency, and you may have to go and do it on an emergency basis also.
Do you have a team?
We don't have a committed team, ma'am, but as you can see, all of us are, we have trained by doing cases nowadays.
So who assists you or who helps you?
Senior obstetrician definitely will be there in the OT, and we should have a good anesthetist, definitely. Intensivist, I can put it. Intensivist is the main key, because surgical part we will do it. But post-operatively, there should be a good intensivist to carry that. So many of the cases we have seen the patient succumbing to the hemorrhage, obstetric hemorrhage. We have seen that's because of sudden cardiac arrest and all. So good management team should be there. It's a teamwork, definitely. Not a single person can do it.
Do you have a protocol? How much blood you keep in hand? How much you reserve?
Not exactly, but we will be ready for 6 or 7 points ready in the blood bank, and we will be.
So if she came in emergency,
And we will see that the amount can be procured in time.
so call for help. If you have not dealt with it and the patient comes in emergency, I think don't open till you have help in hand. Okay, so planning timely accurate diagnosis first step. If we can tackle, we have all resources good enough. If we don't, refer in time. Systematic multidisciplinary planning. For us, we have a backup of surgeon, backup of a urologist. They don't come, but when called, they are available. Senior gynecologist, we do the surgeries. And senior anesthetist will be there, ICU setting, and blood in hand. We have.
Here, who is coming, helping us.
So when you go selectively, better to inform them prior, and so their work is not disturbed or they don't take time to come, because it starts bleeding in seconds. So they need to be in readiness. That is the basis of planning. Ultimate goal is obviously emergency. You have to rapidly mobilize your team, your senior most person. You need a senior most nurse also. You don't need a junior nurse helping this case. Preferably 2 nurses. And good equipment, that pack should be there with the clamps and everything. And pre-op checklists, we have all this. I think with time one can develop these. When to suspect and refer. For single practitioners, if you come across this, risk factors are increased and on scan you're seeing abnormal placenta, please stop and refer. And criteria to consider, where you want to refer, you need to check that they have expertise, they have blood availability, they have the team. Then you can confidently refer to them, you know where to refer. So that they can go in time and get counsel. So this is the criteria for that center. The center should have the team, ICU and blood services. Now when would you plan delivery, ma'am? Dr. Padmaja?
Studies are saying it is better to plan elective delivery by 36 plus 6 weeks. It's almost 36 to 37 weeks. So by the time we can give the steroids to
If the woman has bleeding episodes. Okay, she is now 32.
so it is better to
So they say that if they had previous bleeding episodes, don't take a chance and wait till 36 plus. So maybe between 34 and 36, better to wait off, because it becomes an emergency. And what should the consent cover, ma'am, Dr. Srikta? This consent should be proper, because this is going to save us tomorrow. If, God forbid, mortality happens or some severe morbidity, fistula, whatever. So your consent should cover all this. So who should take the consent and what all should it cover?
So
Can a junior doctor or postgraduate take this consent?
No. The senior proto regarding the entire procedure and what are all the risks involved. Post-operatively also we should tell them regarding all the hysterectomy regards and of course the morbidity involved like bladder damage and ureter involving ureter.
I think it's useful now to make a print. Units are as high as 17%. So better to write, mortality is 7%. Better to write all this and give them in antenatal clinic itself. Please read. We try our best to save all this, but you need to know. So maybe that's a good idea to give them information and then it becomes easier to take consent. So I think you're right, ma'am. Senior person. Yes, video
Yes,
consent.
definitely video consent
Oh, yes.
and even in written also better.
Yes.
Fertility is compromised.
Yes.
That part of it we should highlight and tell them.
Yes. We had few cases, ma'am, where we are conserving the uterus. If the placenta is focally adherent, half the placenta separates and the rest we are sending
We
and
take hysterectomy consent, so we should explain that.
we are taking both. We are taking,
Fertility part then we say, we will have
yes.
it.
Yeah.
So that part.
Even if we conserve, future pregnancy is at high risk of equita again. So they need to know that. But we do get some patients who are insisting to save the uterus. Particularly in some religions, they don't want hysterectomy. So we are taking both. If we conserve, we are doing sterilization. So we conserve. If we remove, obviously that. So all options are covered in our consent form. So when to deliver, timing 34 to 36 weeks, careful planning, multidisciplinary team, risk of preterm versus emergency must be weighed, and pros and cons. Steroid cover, I think all of you have covered this. Scheduled delivery is better than emergency. Good communication between blood bank, us, anesthetist, and surgeon backup. Okay, so surgical, you all agree with me? Expectant has now gone off. Initially we used to leave it close, give methotrexate, all this didn't work. Because we had a patient who came with severe sepsis and boring pus. It was even worse to do that hysterectomy. That is gone now. Planned hysterectomy. Do you all agree with me?
Yes, yes, absolutely.
Because in our setting, follow-up also is very difficult.
She is an early gravida, primary gravida.
Then we have to make an effort to try
Right now, the
to.
case is going on, primary gravida delivered, and 3 weeks since she delivered, her placenta is in situ. Her pulse rate is around 120, WBC count 17,000. We have not given methotrexate, but her
Methotrexate, they are saying, has no role because the tropoplastic multiplication stops by third trimester. So this doesn't, it's an anti-metabolite.
Plastic is causes pancytopenia and nephrotoxicity.
Yes.
I have a case of placenta accreta delivered at Fernandez. My placenta got delivered 1 month after my first child, and after 7 years I had a second baby. So I go more for expectant management.
Okay. Yeah. I agree. So let's keep all this, you all know. 2 ways deep, myometric resection, we are doing these. A few cases we have done. So controversy, skin, vertical, transverse, nowadays transverse muscle cutting is good enough. Uterine incision, we are going fundal, delivering the baby and not touching the placenta and proceeding with hysterectomy. GE or regional, our team is good for regional. They only convert if required. It saves the mother, lungs. Stents we stop. Delayed or immediate, we're doing immediate, we're doing total because the placenta is all over there. How can you save the cell? Transverse, nowadays transverse muscle cutting is good enough. Uterine incision, we're going fundal, delivering the baby and not touching the placenta and proceeding with hysterectomy. GE or regional, our team is good for regional. They'll only convert if required. It saves the mother, lungs. Stents we stop. Delayed or immediate, we're doing immediate, we're doing total because the placenta is all over there. How can you save the cervix? Anyway, you're bleeding. So that stump is another problem. They won't do pap smears. Very difficult to remove stump. We are going for total. Balloons we did to reduce the blood.
The individual you can vertical vessels are coming. You can just stitch the transversely, taking the full thickness of posterior myometrium or anti-myometrium or ligate, and then putting a Hegar's dilator in between the cervical canal. You will approximate anteroposterior anterior wall and posterior wall of the uterus like the cervicoischemics, which are like we do in placenta preview. Even that says you should have a straight needle. All this should be kept in OT, and that I have done, and does give me good results.
There's one paper. They remove the placenta and they close the uterus vertically, multiple compression sutures. It's called Nausicaa. Please Google it up, they gain good results.
Even Heyman's sutures, compression, vertical compression. Following this, we can put a Heyman's, which is very easy to put, easy to learn also. This is putting an anteroposterior or full thickness myometrium. Everybody can do it. That's what I feel. And uterine artery can be bilaterally ligated, ascending bract, go down as far as possible, because once you push the bladder down beyond the internal loss, and that should be done before you plan your hysterectomy incision. Then you will not have time to push the bladder. So push the bladder, taking a sharp dissection without injuring the myometrium. So
we need to follow checklist. help improve, reduce blood loss, improve your outcomes, use MRI selectively, and cesarean hysterectomy is a gold standard for our setting. Elective second step procedure is an option in selected cases. Conservative options can be used. There are new things coming, a linear vessel cutting and sealing system. They use this even to give uterine incision. There is just no blood loss. You reduce the blood loss dramatically. So new things are coming. We should keep our eyes and ears open, but we should not lose a mother at the end of it in this day and age. Thank you so much to all my panelists for your crisp answers. Thank you.
Thank you so much, madam. I request Kameshwari madam to present the mementos to our panel members. I request Kameshwari madam to present the memento to Dr. Snigdha madam.